This morning, we will go into more details about treating intracranial aneurysms. So, as we know, historically, the treatment of these aneurysms has always been a dream of endovascular surgeons or interventional radiologists. So, the first person who attempted treatment was Serbenico. What he would do was he would put a balloon inside an aneurysm and inflate it and detach it, but it never would work because the pulsation of the balloon would cause the aneurysm to grow. Then after that, people tried putting magnetic fillings. That also did not work. So it was finally Guglielmi who actually came with a product that would work. So Guglielmi was in Italy. He used to work in his brother's radio repair shop, though he was a radiologist and also a surgeon. And he noticed that when electrical wires were being soldered and if a current was allowed to pass from one end, at times the soldering used to give way because of the heat generated due to the resistance in the wire. So, keeping that in mind, he tried to make detachable coils which could be uh, absolutely controlled in terms of the length you want in and whether you wanted to pull it out or put it back. And a company called Target would finally partner with it and start making the first coil. Later on, he would actually move over to US and working along with Vinula started coiling of aneurysms in the early 90s. So the first coils were all like these. They basically were helical and they had a point of magnetic detachment, electrical detachment here, and you would place these coils inside. The coils all came with a standard stiffness. Very soon, people realized that this was not going to solve the problem of all aneurysms because this could only fit inside a narrow neck aneurysm, and that too one which was not very small. The problem, what was happening was this mandrel was invariably stiffer than this coil. So when they were pushing these coils inside, the coil would go, but the mandrel was piercing the wall of the aneurysm. So the whole concept of making coils would change. The first thing they did was to change the coils from helical to more complex shapes. So every company thought about this. For example, Target, the very company that started making coils, started making this complex 3D shape. Now, what they did is they presumed that this small loop would actually sit at the neck. This would fill the coil much better than a helical aneurysm. So, uh, than the helical coil. So, these 3D they found was actually going and framing the wall much better than the classical helical. Exactly in same lines, companies like these, this is basically a company called, which was again barricade, which was or a blockade was made by a company called Micros. They started making coils. They were more like a box. The idea of the box was they felt at the neck it would be flat, it would not pierce, but it would fill the wall of the aneurysm much better, and then would allow concentric packing of other coils better than just having a helical, because the helical's problem was it was crisscrossing across the complete aneurysm, and thus filling was not extremely good. And then we got another company called Microvention. Now they made their coils look a little more spherical. But the basic concept was everybody started feeling the initial first few coils was better if it had a three-dimensional shape rather than a helical shape. So in other words, today we have to understand that the first coil you would try to put in any aneurysm is preferred to be a three-dimensional shape than the helical shape. But having said that, the last few coils is better to be helical because they tend to find interspaces better than a classical 3D coil. So thus we have a 3D coil and a helical coil. So these are the two main classification when it comes to shapes of coils. But like I said, there was another issue. The other issue was the stiffness of a coil. So if you have a very small aneurysm, if the coil was just as stiff as that in a 6 mm aneurysm, then the coil would rupture. So coils became classified as standard, soft, and ultra soft, and people will call it by different names. For example, this is a framing coil. A framing coil is expected to give a good frame and also give a stable protection across the neck. If you use a very soft coil in a wide neck aneurysm, it will tend to prolapse out. And then you have got a coil which is labeled as soft. Now, what is soft? Soft is also a reasonably good framing coil when the aneurysm is, say, 5 mm or less than 5. So this is a 4 into 6 soft. Basically, it means these are better suitable for ruptured aneurysms rather than the standard aneurysm. Then, even softer than that, you will have a coil which is called the ultra soft. The equivalent to an ultra soft in another company could be like this. Now, Barricade uses a term called helical finish. Finish means these are really soft, can find spaces in the end. And for example, Microvention will use this term called hydrosoft. Now, all of them have got nearly the same softness except the nano coils that come from Stryker. Now, the nano coils are basically, as the name suggests, these are the smallest of the coils and the softest of the coil, and basically they are used for very small 2 mm or 2.5 mm ruptured aneurysms. Okay. Now, one of the things, how do they make a coil soft? It's basically by changing the stiffness of the platinum coils that they use or the thickness of the platinum coils they use. Remember, a coil stiffness is also to be matched by this mandrel stiffness. So one of the things also is in all the ultra soft coils, the mandrel will always be much softer, which will allow you the mandrel's terminal end to behave just like a coil. Okay. So detachment of the coils are variable. This is an electrically detachment system. This is also an electrically detachment system. This is also an electrically detachment system. But whereas the EV3, which is the Metronic, will use a mechanically detachable system, which basically has an outer sleeve that will pull out, right? So that doesn't really make any difference as long as you know what is the device that you're using. Okay, so that's a little bit on the structure of a coil and how they are made. We also talked in a previous talk that coils are made stretch resistant. How do they make them stretch resistant? The coil is wound over a nylon thread, and the nylon thread will prevent the coil from stretching beyond the determined length. For example, you have a coil which is 4 millimeter in diameter and is, say, 8 centimeter in length. So the nylon thread will be 8 centimeters. If you do not have a stretch resistant coil, it can get caught into the aneurysm, and when you pull it, it will keep stretching and stretching and stretching. And that can be a bit of a mess, and you will not even be able to pull the coil out. Okay. So that's a little bit on the different technology of coils to understand also how coils are made. Coils are all made manually. They're not very easy to make coils. Actually, that's why they cost a little more. They are like little knobs. They have to be wound around them depending on the shape you want to give. And then they are finally baked in an oven-like device, which heats the coil, gives it the shape, and that's how coils are finally made. And that's where there's a lot of wastage also what takes place. Okay. Now we'll go into a little more detail into the structure of a coil by actually opening some coils and seeing. So let me just pause a little bit as I show you that.
So now we will show you the behavior of a helical coil. So have a look at the coil. As the coil comes out, it forms a straight loop and then it starts taking circles. So technically what happens is, what people feel is if there is a wide neck aneurysm, it may not sit inside this. And this is the mandrel that comes out. See, the property of the mandrel is very important. You see, if the mandrel is stiff, it can perforate the aneurysm. You can see it. This is exactly what happens in the aneurysm. Instead of forming a loop, it goes straight. So remember, when you're working with a small aneurysm, do not push this mandrel too much. Rather, it's better to push it just halfway through to the marker and then pull the micro back a bit. Okay, I hope you understand. So this is the property of a helical coil. And like I said, the advantage of the helical coil is, although it may not exactly form a great basket, it will find spaces inside, and it will tend to get inside the interstitial spaces of aneurysm which is partially coiled. So remember once again, a helical coil is a good finishing coil. A helical coil is also a good filling coil, but it's not the ideal framing coil. Okay, so from here we will go to the next shape, which will be a 3D coil, and let us see how the 3D coil behaves inside the same syringe. So let's have a look how a 3D coil behaves. Now when the 3D coil comes out, the first loop often is a small loop. Now why do they make a small loop as the first loop? It will not tend to get hitched on the wall of the aneurysm, which can induce rupture. It is this loop that will ride forward, draping the aneurysm, and the second loop is a larger loop. Can you see that? It's a larger loop. And then you see it drapes along the wall of the aneurysm rather than the other, which was following helical loops. Now this is a good property which is called basket. So the ideal coil should make a good basket which will stick on the periphery. So if you match the coil to the size of the aneurysm, you will get this property. Can you see that? It is going all over. It is not distributing to one corner, and it is not producing a compartment, which is more common if you use a helical coil as the first coil. But remember this property. Here comes the mandrel. You can see the soldering point as it comes out. Can you see that? And you see in reality, even the softest coil, this segment is always got a different behavior. So you understand, you push hard, what happens? It will tend to go straight. But look, this is an ultra soft coil. Even though we are pushing it, the ultra soft coil has an advantage that it will take a curve. The mandrel is taking a curve, right? Of course, you got a limit on that. But even then, be careful. Make sure we do not push it more than the marker, because it is a dangerous thing. So this is the 3D coil shape. Like you see, whatever you do, you will find there is a difference. Like I said, the first coil is small. The coil rides forward. As it touches the wall, it allows this to break, and it takes a 360-degree curve over and over and over again, covering the whole aneurysm. Okay, have you got that? So that is a property of a 3D coil. Fine. So coils are good, but we realize one of the problems with coils is when we have a wide neck aneurysm. It gets worse when this neck incorporates vessels. So there always has been a lot of research as how to solve this problem. When we have a sidewall aneurysm, the preferred device is to use a flow diverter. Of course, before that, we always know that we use a balloon-assisted coiling, which I will talk in the next class, which is probably the best way to treat an aneurysm where the neck is wide but not greater than 70% of the dome. Now, if it gets really large, like 1:1, they won't work. Also, the problem with balloons are that if vessels are incorporated in the base, for example, classically, let's imagine a middle cerebral artery location, the bifurcation has an aneurysm, and the vessels are rising from the base, then it becomes difficult. To circumvent a location like the middle cerebral artery, or an anterior cerebral artery, or the basilar artery, or in other words, an aneurysm which is wide-necked at the branching point, devices were made which can be intra-aneurysmal flow diverters, or they stay within the aneurysm itself. And the most popular of the device is a device called the Webb device. Webb device is currently available at Microvention, and let me show you the property of this. So this is a device, the tip has a radio opaque marker, and it is a device that looks very much like a ball, but is exceptionally soft. Now the number of wires in this will vary anything from 144 to a lesser number depending on the size of the lesion. And these wires are made of nitinol, which are radio opaque because they contain a hollow tube which has a platinum wire inside it. Now these are like 0.007 of a inch, so you can see these, they form a tight mesh. Not only do they form a tight mesh, if you look at the fundal position of this, it becomes really condensed because it's concave. The advantage of this concavity is it doesn't hit on the fundus, also forms a good density which forms a bridge for endothelium to grow. Now this looks kind of rigid when you see, but in real life it is so soft it will completely collapse. Have a look at it. This is without much pressure at all. So the advantage is that it is a very safe device to be used even inside a ruptured aneurysm. Now when it's at this location, it can be a little stiff. Once it comes to this point, it becomes very soft. And I'll show you this property. Have a look at this. So we are going to move this forward in this. Can you see it is this soft? Can you see that feel? It is just a gentle touch and it gets this soft. So remember, at this position, when you're coiling and when you're putting a web device in an aneurysm, technically you can push it up and down, it will do nothing. It can never rupture an aneurysm unless you push the catheter itself out. So it is the safest device and the device which has got the largest numbers of studies possible on an intra-aneurysmal device. The other device, which is called the contour device, is a little different. Now what is the difference in that? It is like half of this, and unfortunately it has got a convex outer border and very often will continue to hang inside the not inside, outside the aneurysm, which can sometimes make it a little difficult. Okay, so this is the web device. Now sizing the web device is a chart, but a simple concept is if you compress it by 1, it elongates by 1. For example, this device is suppose 4 millimeters in diameter and 4 millimeters in height. If you put it in an aneurysm which has got a diameter of 3 mm, the height will go to 5 mm, right? So that's how we'll calculate. And this is electrically detached. So this is the web device and probably the most popular device available in the world today for intra-aneurysmal treatment. So technically it means it can also be used in a narrow neck aneurysm, but imagine if it's sitting on an aneurysm right inside, the vessels in the base will get spared. Okay, I hope you got the hang of it. And like I said, it's pretty simple to use it. Technically not challenging at all. It's sizing that can be bit of a challenge. The other device is a contour device, but most of the publications worldwide have been on the long-term results of the web, and contour only time will tell you as to how reliable it is for everyday use. So the next device is called a flow diverter. Now the flow diverter and the stent are more or less similar except the amount of braiding that is there in this. Now this is an interesting flow diverter, and this is made by a company called Microvention, and it is called the Fred. Now what is the property of the Fred? Can you see the distal end is flared out? The distal end has got radio opaque markers. You can actually see it on this macro image that we are taking for you. And can you see the number of filaments are several? Now unlike any other flow diverter, this is a dual layered flow diverter. What do you mean by a dual layered flow diverter? They have got a stent which is called the Elvis, and inside the Elvis they have put another mesh which has got a much more larger number of filaments, like 64 filaments, and thus it's got a combination of a stent and a flow diverter together. Now this is a flow diverter which is made with nitinol, and if it is nitinol, the advantage of nitinol is that it has shape memory. Disadvantage of nitinol is that it is not very radio opaque. Now it's a very, very flexible device which can be bent in to take any shape, but we will show you some PowerPoints later in another talk as to how one should actually allow the flow diver to actually conform to the vessel wall. The other flow diverters that are available is the pipeline, which is not made of nitinol, it's cobalt chromium. So also we have another flow diverter called the surpass, which is cobalt chromium. We have silk, which is nitinol, and we got the derivo, which is nitinol. Now, if somebody asks us which is the best flow diverter, technically I think the best flow diverter is the flow diverter with which you are most comfortable with. Having said that, the Fred is not a great flow diverter if you have to come from a narrow to a larger vessel. So, what do you mean by narrow to a larger vessel? It is like telling if you want to come from the MCA to the ICA, because of the double layer, it tends to get a little more thrombogenic. Okay. At the same time, so if you want to use that, it's safer to use a pipeline device or a surpass or any of these devices, which probably adapts a little better. This is my personal feeling. It is technically not from the literature, but like I said, the best thing you can do is to use something you're most comfortable. Also, we realize certain devices like the Derivo are the easiest to deploy, but the flow diversion is the lowest. So, we feel that in a patient who's got a ruptured blistered aneurysm or a ruptured saccular aneurysm that needs a flow diverter, use a device where the flow diversion is better at the time of deployment. Most of these will ensure that the aneurysm heals by 6 months, and that point the difference may not be very significant, and that's why I said it's more important that you are comfortable with the device that you use. So like I said, this is a flow diverter called the Fred, made by Microinvention, and the biggest advantage of this is the flared ends, which allows easy anchoring, which can be done. So when you take a flow diverter into a vessel and you deploy it, see, it can take these shapes which are very tight, and all of them will do it. So the thing what really happens is they may not really take this, but sometimes they will kink. And this kinking is can never be demonstrated outside, can only be demonstrated inside the vessel. Also remember that these should never twist. If they twist, you completely lose it, and that's why deployment should always be done in a very regular way. Now see, you can stretch it. This is how it's loaded, and as they get released, they will come back to the size. So you get this property. I hope you can understand what really happens inside the body. And interestingly, flow diverters have got this beautiful property that they do not occlude branches unless and until there is a competitive flow from the other side. Okay. So remember one more time, flow diverter is the best device for sidewall aneurysms.
Finally, in conclusion, coils, flow diverters, stents, and intra-aneurysmal devices can all be used to treat aneurysms. When you have a narrow neck aneurysm, the treatment is very simple. It is just coils. When you have a broad neck aneurysm, which is between 50 and 70%, you can use a balloon assisted coiling. When it gets more than that, or especially when the aneurysm is shallow and the dome and the neck are nearly of the same diameter, then one has to think of putting a flow diverter if it is a sidewall aneurysm. But on the other hand, if it is a branching point aneurysm, like the anterior communicating artery or the MCA or the basilar top, then you can consider using an intra-aneurysmal device like a web device. All the devices have their advantage and disadvantages, but technically, in a ruptured aneurysm, it's ideal to avoid a stent or a flow diverter. Why is that so? It's primarily because you'll have to start the patient on dual antiplatelets. And if the patient has any complication requiring a surgery, especially something even as small as an EVD, can become an extremely complicated procedure
if the patient is on antiplatelets. So that is a thumb rule, but sometimes we have to uh, go beyond the thumb rule, especially if you have a blister aneurysm, where the only treatment possible is a flow diverter. Also remember that spasm along with a flow diverter is a bad combination, or a spasm along with a stent is a bad combination. The device will thrombose and again result in a further complication. So this is a little bit of a summary on handling coils and stents, flow diverters, and intra-aneurysmal devices. And I hope that it has helped you in some way. Thank you.